Hello and good evening to all the viewers. This is a very important session, Approach to Medicine PG Residency. And I think it's a very important session, considering the fact that students have got the NEET PG results recently, and now they're planning to take the post-graduation of their choice. And we all hope it is going to be general medicine for many of you. And also for the residents who are currently doing your residency, be it first year, second year, or final year. So we'll try to cater to all group of students. Okay, those who are doing residency as well as those who are just about to join residency. With me, I've got eminent panel of super specialists who are actually leading super specialists in their respective departments. And all of them are faculties at DocTutorials for the super specialty segment as well. So just introduce all of us. First of all, I'm Dr. Rahul Rajiv, and I'll be handling neurology along with Dr. Pooja Anand. Welcome Dr. Pooja to the session.
Thank you, sir.
Then we've got Kamal Sharma sir, who will be handling cardiology. Dr. Nia sir for infectious diseases. Dr. Karthik Vijay Kumar for endocrinology. Dr. Prashant Gandhi sir for medical gastroenterology and hepatology. Dr. Hemant sir for oncology. Dr. Vishnu for rheumatology. Dr. Shinto sir for hematology, and Dr. Mithun sir will be discussing on emergency medicine. So I think I'm sure that a lot of queries will be there by the viewers, and some of them are routinely asked queries, and we'll be addressing them first. And subsequently, we'll take up the questions in the chat box as well. So if you have got any queries regarding general medicine residency, please feel free to type in the chat box. We'll be answering those questions as well. Right. So I think we'll start off, this discussion. And let me just also tell you that all the points that we'll be discussing is to help you become better clinicians and thereby, have a good career as well. So do listen to the entire session to get maximum benefit. So I think we'll start. So to begin with, the set of discussions that we will start off is regarding the importance of each specialty. Now, medicine, we know, is a wonderful branch. And if you have chosen medicine for your specialization, I think most of you have got a good choice here, because medicine is such a wonderful branch with so many ramifications. And the perfect example of that is the panel that you have here, because all of them are experts in their own segments. So there is a possibility of a lot of explorations. It's like, going on a trip, you can go in multiple directions, but all the journey, whether it be rheumatology, neurology, cardiology, the journey is actually going to be very beautiful. So we'll start off. The first set of questions will be pertaining to each subspecialty of medicine and how to excel in that. Because I've got many queries from students who are joining medicine residency, as well as those who are joining or those who have already joined residency, on how to approach, say, endocrinology or cardiology or neurology. It's always nice to have an orientation so that with that background, you can actually move forward. So I think we'll start with Dr. Karthik. So Dr. Karthik Vijay Kumar, he is actually the endocrinology faculty in DocTutorials. So Dr. Karthik sir, he has, Dr. Karthik, you are online, or have you?
Yes, sir. Yes, sir.
Yeah.
Am I audible, sir?
Yeah, 1 second. So,
yeah. Okay.
Yeah. So we'll start with Dr. Karthik. So Dr. Karthik is the endocrinology faculty of DocTutorials. So he has done his DM in endocrinology, and followed by, he is actually the recipient of the DRNB President's Gold Medal Award for endocrinology. as well as the winner of several national quizzes for endocrinology as well. So Dr. Karthik, you are the right person to talk on this. So as the endocrinology faculty of DocTutorials, can you just discuss on this point, how to approach endocrinology as a medicine resident? What are the common cases that you encounter? And, at the end of residency, what is expected out of a good physician in terms of endocrinology?
So thank you, sir, for giving me this opportunity. First of all, congratulations to all the students who have cleared their NEET PG examination. And most probably, I'm hoping that you'll all be selecting the medicine branch. So it's very interesting that Rahul sir has started with endocrinology, because I thought the other specialties like cardiology, neuro, nephro might be getting the first opportunity. So anyhow, so I would like to answer the question that sir has posted in 3 parts. So for a person who is newly joining the residency, he or she should be knowing why a sound knowledge of endocrinology is very important for a physician or a medicine resident, number one. And number two, what realistically should you expect during your residency regarding the exposure to endocrinology? Of course, there may be exceptions, but in an average college, if you generalize the pattern, what is the average exposure to the endocrinology cases? And third, if you want to really look into the endocrinological cases and want to read up, which all sources should you refer? Okay, so coming to the first question, why is endocrinology important for medicine residents? Myself having been going through the 3 years of residency and senior residency as well, and from experience from a lot of colleagues, juniors, seniors, and many of you may be already doing your residency as well, it is pretty obvious that as residents, we are mainly focusing on your emergency work, that is the casualty-based work or the inpatient-based work, right? Mostly 90% of the work will be pertaining to either of these. And the OPs will be mainly run by the consultants. So, but once you pass out after 3 years of your medicine residency, when you start your own clinic or when you join a super specialty course, so you are expected to know some basic aspects regarding endocrinology. For example, while you are running your clinic, you should know how to tackle a patient with difficult to control diabetes. When you start your practice, it is very obvious that the diabetes mellitus, the thyroid disorders, and the community acquired infections are perhaps the 3 most common cases that you are going to see, and not the myocardial infarction, stroke, heart failure. All these things are very important, but these are not the things that you see every day in your clinics. Okay, and most of these cases are managed by super specialists nowadays. But as a resident, you are expected to perfectly manage a person with diabetes in the OPD and in the IP basis. And if a person is coming to you with difficult to control hypothyroidism, or if a patient is having thyrotoxicosis, whether you are able to differentiate whether it is a Graves' disease or thyrotoxicosis, all these things are expected of an medicine resident who has done his MD or DRNP medicine. Okay, so even when you are going to do your super specialty, all the cases, like you might be doing cardiology, neurology, nephrology, diabetes mellitus, thyroid disorders are common accompaniments and are comorbidities in many of these patients. And you just cannot expect endocrinologists to come like on a daily basis to manage these things, because you yourself are qualified at least to give the preliminary management. So overall, these 2 major endocrine disorders, the diabetes and thyroid, are extremely common and are extremely important for medicine residents to know in and out. Now, coming to the second question, the most important one, what is the exposure that you are getting regarding endocrinology in your medicine 3-year residency? Like as I told, most of the institutes that offer MD or DRNP medicine doesn't have a dedicated endocrine department. Okay, so many of the students will not be getting the specialty posting in endocrinology in their 2nd year, whereas all the other super specialty or subspecialty, whichever you call them, you will get like dedicated posting for them. But endocrinology, most of the colleges will not be getting. And the diabetes mellitus and thyroid disorders mostly are managed in an OPD basis. And I've already told you, you have a reduction or you have decreased exposure in management of OP cases. And the other endocrinology cases, like the adrenal insufficiency, all the adrenal disorders like aldosteronism, Cushing syndrome, or be the pituitary disorders like acromegaly, hyperprolactinemia, these are not very readily apparent to you. Just like unlike heart failure or stroke, whether we can readily make the diagnosis, here you need to have a high index of suspicion in identifying and diagnosing such conditions. So that is why many of the endocrine disorders go unnoticed. You may have already come across many such patients, but it is very likely that you have missed the diagnosis. It is mainly due to the lack of exposure to the endocrinology and the lack of sound endocrine knowledge. I myself had gone through this phase for the 3 years of medicine residency, and I can very well vouch that even after passing my MD residency, I was not confident of perfectly managing a patient with diabetes or thyrotoxicosis. And all this knowledge I have gained only because I have gone through my DM endocrinology. So I just thought, what better advice can I give to the students to prepare endocrinology in a better fashion during their MD residency days itself? The problem with endocrine is that, if you want to read about diabetes, thyroid disorders, adrenal disorders, pituitary disorders, all these things, or emergencies like DK, thyrotoxic storm, you are going to refer to your Bible, that is Harrison. But the problem is that all the pathophysiology, etiology part is very well described in Harrison, but the management part is not well elucidated. And many of the drugs and newer treatments may not be available at your area also. So this is what I have tried to do in the DocTutorials medicine residency program itself, where we have carefully formulated that package based on the practical utility. So how to practically approach a patient with, say, hypercalcemia, how to practically approach a patient with uncontrolled diabetes, how and when to start insulin in a patient, what are the things that you do to follow up. So all these finer aspects that I'm sure you will never get during your residency because of lack of exposure to endocrinology. I think I've covered pretty comprehensively in the medicine residency package, and it contains the information from various guidelines, textbooks, and whatever information I have gathered from my teachers and seniors, all this in a very practically feasible manner. So in a nutshell, I'm going to tell you that the exposure to endocrinology is not going to be that great, mainly because endocrinology is a predominantly OPD based specialty, and here you will be focusing mainly on the emergencies. And I think we have a very good source for learning for medicine residents with regards to endocrinology in our residency program. And once you get rolling in your residency, you can very well subscribe to that course and get used to it.
Okay, thank you, Dr. Karthik, for the valuable insights regarding endocrinology. So I also just want to put a point on how the residency program of DocTutorials is slightly different from the NEET SS and INI SS programs. So initially we have come up with this super specialty entrance related program, and which was very successful with, I think, the maximum candidates across India, but in both the medical and surgical, and now the pediatrics specialty segments, they're actually preparing from DocTutorials. But for the residency segment, what we have done is we have actually delineated these two programs. In residency, we are actually going it from a, say, a clinical perspective alone, rather than an entrance perspective. So when Karthik deals with, say, a problem like diabetes or a thyroid disorder, in the residency program, he'll be training you to become better physicians. Nothing with regards to entrance, which will be dealt in the entrance segment only, but this one is to train you become better physicians. And I think every resident has to know about management of common diseases, and that is very imperative. And that is what we have focused maximum in our residency program. So thank you so much, Dr. Karthik, for joining and giving your valuable insights regarding endocrinology. Now we'll go to Dr. Vivek. So Dr. Vivek is currently a leading nephrologist in Kolkata, and I think he has years of experience teaching students. And currently, he is the super specialty faculty for nephrology at DocTutorials. Dr. Vivek, the same question for you is on the approach to nephrology during medicine residency. During the training period of residency, what are the common cases that they would encounter with, and how should you build your knowledge for nephrology? So please, guide the students on that.
Good evening, sir. First of all, thank you so much, and welcome to all the residents who are hearing us today. So, what I'm here to discuss is how should a medicine resident approach nephrology during his residency. So, you know what, when I was a resident, I still remember before entering, I asked my senior that what are the 3 years of medicine residency like? And he told me the 3 years in a nutshell. He said, Vivek, in the very first year, it is fully ward work. In the second year, you will be busy with your super specialty postings. And in the third year, you will have to read intensively because you've got to prepare for your MD finals as well as you've got to prepare for the super specialty entrance. So I did follow those footsteps, of course, with my own modifications. Now, in the very first year, you shall be dealing with a lot of nephrology cases. So the very first task as a medicine resident is to delineate the nephrology syndromes. What I would like you to at least be able to, by the end of first year, be able to delineate what is an acute kidney injury, what is a chronic kidney disease, what is a rapidly progressive renal failure, what is a chronic glomerulonephritis, what is a chronic interstitial nephritis, and so on and so forth. You may not be able to go into the deep down details, but at least the syndromic diagnosis you must be able to approach, because this is how you shall ultimately develop your skill as a physician. Of course, second of all, you will be dealing with arterial blood gas day in and day out. So a skill set so as to be able to draw a arterial blood sample, very basic essence of a first year medicine resident, and to interpret the ABG effectively. Because at the bedside, the ABG interpretation can give you a host lot of information. You might be well sound with the theoretical aspect of it by now, but how to practically apply it, how to practically treat it. Number 3, management of dyselectrolytemias. Be it a neurology patient, be it a gastroenterology patient, day in and day out, you will find hyponatremia, hypokalemia. I still remember those days I used to run around and keep asking my seniors, sir, I need to give 40 milliequivalents of KCl. How do I give it? Because, each book would differ here and there, and the practical application of it would differ here and there. So those things which look very petty in the hindsight were actually very big to us when I was a medicine resident. So you need to be very sound with these knowledges. Now, another skill set that you need to be able to do by the end of first year, which I was at least able, is to put a central line. Because when you know how to put a central line, then also you are able to put a dialysis line also. Because that also you must be able to do. Then a very important skill set is volume assessment of a patient. So bedside, you must be able to assess whether the patient is in a state of central volume overload, whether you need to give fluid to the patient or to give diuretic, because this is a very common scenario which is very easier said than done, which I see young residents faltering at. They do not know how to manage the volume status of the patient. Coming to the second year of residency, you shall be posted in your respective nephrology super specialty rounds, and so you must have a basic idea of how a dialysis unit works. You must try to at least watch from a very observant eye what is a dialysis machine, what is the tubing, what is the blood flow that the nephrologist has advised, what is ultrafiltration, what is plasma exchange, because you might not be able to know the intricacies, but at least you must be familiar with these terms. Because I still remember, I'm still trying to recall my residency days and giving you the insights about that. if your hospital is a transplant unit, at least go see what is a kidney transplant done. I still remember those days vividly when I first got to know that when a patient has a kidney transplant, the transplanted kidney is put into the right iliac fossa. So the a recipient has three kidneys. So I still remember that day when it was an enlightening moment for me. So these things you cannot learn unless you have physically gone and seen in the unit. Now, coming to the sources, first and foremost, of course, your Bible, your Harrison has to be read thoroughly. A little addition to that, if you just want to pass your MD finals and cover the nephrology, you've got to study the KDIGO guidelines for CKD, KDIGO guidelines for anemia in CKD, and KDIGO guidelines for CKD MBD in CKD. And I would give a special reference to Up to Date. Please make it a point to at least subscribe to Up to Date and keep it in your smartphones, because especially this electrolytemias management, the guidelines at what rate it should be given, that was very, very handy when I was a medicine resident. And if you target nephrology as a super specialty subject in the third year, or actually in the second year, you should refer to books like Brenner's and your Fihali's textbook of nephrology. And of course, the residency program has been briefed by the previous speakers, so I wouldn't go there. But yes, we have curated the programs very, very meticulously. And for example, when I teach hyponatremia in a residency program, I don't start with the classification of hyponatremia. I start with a patient who's come to me and he has a sodium of 122. And how do I approach him? How do I manage him at the bedside is what we have discussed in the residency program. So yeah, I mean, the talk, I can speak for us, but to cut it short, I would like to keep it this, sir.
Thank you so much, Dr. Vivek. I think for that very concise, but I think you've covered all the important points that somebody who is joining medicine residency should know. And as you said, it's a beautiful branch, and I think as you explore medicine in this journey of the residency, you will find a lot of fascinating things, and I think it's a journey that all of you will enjoy as well. Thank you so much, Dr. Vivek, for your
Thank you, sir.
thoughts. So now I think most of the people who join medicine residency or say MBBS, they're often fascinated by the heart. Okay, so I think, I've spoken to so many MBBS students, and whomsoever likes medicine, the first choice is usually cardiology. And I'm slightly jealous of that because I am actually from the neurology specialty. They do give us, but again, it's usually second fiddle to cardiology. So I've got Dr. Kamal Sharma, sir, an eminent cardiologist. He'll be discussing about cardiology during a medicine residency. So Kamal, sir, keeping in mind first year medicine resident, so what do you think, how to approach this subject of cardiology? So vast. But again, what is expected out of a medicine resident during the 3 years of training? And once he comes out as a physician, what are the basic qualities that he should be having?
Good evening, everyone. Thank you, Dr. Raji, for giving a very beautiful outline for the branch. Actually, as you mentioned, I recollect my first day. When you have a first day, you have to attend a casualty call for somebody coming with breathlessness, and you're scratching your head whether it's a respiratory breathlessness or a cardiac breathlessness, whether you want to push in a derifylin injection or a diuretic injection. So it starts right from that moment for a first year, because sometimes the hospital protocols may have the third year look after the casualty calls. A lot of busy government hospitals will make the first year actually go into it in the right day one, and that's when the whole story starts. Now, coming to the important points, then important aspects in cardiology that one needs to learn, I will elucidate three important aspects. One, the important disorders that one needs to learn. One, of course, every other patient is going to be either hypotensive or hypertensive. So this is one of the basic things that one needs to learn. When do you call a patient hypotensive? Remember, 100 systolic, a lot of patients will come without symptoms in OPD. Don't assume they're hypotensive and put them indoors. A lot of patients with 170 systolic who are moving around may also not require the same. And that's why it's important to know the clinical perspective. And again, what patients require what treatment for the hypertension, which may be present with diabetes, with CKD, with acute stroke, and you need to see overall in the perspective. Number two, very important disorders that everybody must cover and see is acute coronary syndrome. Basics of an ECG. It is said that 90% of the ECGs done in any department are normal ECG. So first learn a normal ECG. And in that context, I also want to bring around that we have in the DocTutorials PG program, I had done 3 recordings of ECG and Dr. Rahul Rajiv called me back saying, sir, we want at least 10 recordings for an ECG. And so we did how to do a basic ECG, how it is a normal ECG to be interpreted, because that's a very important perspective for somebody who's come from an exam after the clearing the exam NEET PG and has joined residency without much exposure in the ward. It's very important that one goes through the basics of an ECG and interpretation of X-ray. And third important thing is a CPR. There is no way that you'll get away doing an MD in any branch or DM in any branch and you will not be doing a CPR. Very often you will end up doing a CPR either in your OPD, indoor, your hospitalized patient procedure. And that's why you need to know this aspect as well. Coming to books, Harrison, as was mentioned, do something for drugs, which is OPI is what usually we recommend. And ECG, 3 books you must do. If you're very keen in cardiology, Grunwald's textbook it is. Be selective, do diagram table flowcharts. But as they say, first year, you will see whole of Harrison patients, all the chapters walk through your wards. Only thing is your brain would not know. And that's where DocTutorial app would come in handy. You'll see those diagnoses if your brain knows it. So your eyes see what your brain knows. And for that to know quickly in first year, I think residency program is fantastic. Of course, once you do a second year rotation, you have exposure in the specialty, come back in third year, you'll be much wiser and that will help you a lot. So the 3 important things, as I said, hypertension, acute coronary syndromes, acute MIs, arrhythmias, and CPR. These things, if you can cover, they will be the vast majority of the things. And if you're focusing on super speciality, remember, don't look at the eye of the fish as Arjuna was targeting in Swayamvar. You need to look at the whole fish. That's where the super specialists tend to miss. So very often the exam long case in DNBs are mitral stenosis with embolic stroke, SLE with pleural effusion. You'll have to find out multi-system disorder. God usually is kind enough to give you 10 symptoms of a disease rather than 10 diseases with 10 symptoms. And that's the whole fun, charm, and greatness about subject like medicine. That's this in short, and the rest of things I think a lot of other speakers have already spoken, and I think others will follow as well. Over to you, Dr. Alraji. Thank you.
Thank you so much, sir, for that enlightening discussion. And I'm sure that cardiology is one subspecialty which all students would be fascinated with during medicine residency as well. Now, just to quickly address a couple of queries in the chat box. So first is regarding the pulmonology modules. So I can see the queries. So as I said, in case of the medicine residency program, it's a hybrid program with both live lectures as well as recorded lectures. And Pulmo faculty has already joined, and new recordings and new videos will be there in the app in the coming few weeks itself. So do not worry regarding that. Pulmonology videos will also be there in the residency program. No need to worry about it. Second, I can see one query regarding Harrison's tables and flowcharts in the residency plan. Well, Harrison's tables and flowcharts, the set of videos that we have curated, well, they are specifically meant for the entrance exams. As I said, we have clearly demarcated the residency program from the super specialty segment, super specialty entrance segment. So the Harrison's tables and flowcharts, we have discussed the important points pertaining to the entrance part. Okay, that we have covered. And I think there is nothing to worry because all the important points have been covered in the residency lectures as well. So even if you watch the residency lectures, the gist of everything is actually provided. For example, if say Dr. Karthik is discussing a particular topic or Dr. Prashant Gandhi sir is discussing a particular topic, whatever is relevant in the context of that topic, they are the experts and they will definitely, put their lecture in that context only. So there is nothing to worry regarding that. Okay, right. And also regarding rheumatology, yes, rheumatology videos are also like Dr. Vishnu is doing the videos, and do not worry regarding that. And since Anil, you have asked that, I think I'll address the next question to Dr. Vishnu, who is the rheumatology faculty of DocTutorials. So Dr. Vishnu is the rheumatology faculty at DocTutorials, and Dr. Vishnu, compared to branches like neurology, cardiology, medical gastroenterology, when somebody enters medicine residency, the relative awareness about rheumatology is considerably less. Now, what you have got to say about this branch of rheumatology and also on how to approach rheumatology during residency?
Sir, so as you correctly said, the awareness or the touch with a specialty like rheumatology, especially with respect to the management aspects, is limited because there are still very few rheumatologists that have joined as faculty in most of the medical colleges. So there is a dearth that wise, but obviously there will not be a dearth with respect to the patients. The patients will of rheumatological disorders will be coming to the hospitals, and at every juncture, be it your first year, second year, third year, you will be in contact with those patients. So I've kind of divided the approach to rheumatological disorders based on the year of a possible medicine resident. So in first year, the resident should mainly, as Kamal sir said, the syndromic approach, and Vivek sir said, syndromic approach is very important. The student should be able to recognize whether or not the patient who has come is a possible rheumatological illness or not. So there are certain indicators like multi-system involvement, especially integumentary system, MSK system, or even hematological system. So you have to kind of delineate whether that patient can be a possible rheumatological disorders. And then you have to also know when to order a rheumatological investigation. So this is especially very important because a patient might just be the first presentation of a rheumatological disorder presenting with just an AIHA or an ITP. So these are conditions where you should go ahead and do a screening test such as ANA, especially if it's a young female presenting with a rapidly progressive renal failure. You should go ahead, do an ANA and an ANCA to test for a possible SLE, possible vasculitis. Whenever there is a thromboembolic phenomena, always you should understand that you have to send an APLA profile. You should look for a possible Behçet. Similarly, pulmorenal syndromes, you should always look for a possible SLE, a possible vasculitis that can cause a pulmorenal syndrome. So these are cases where you will encounter in your wards, in your emergency wards, as well as in your OPDs, as a first touch of the patient. And there you should not miss these investigations because these are first line investigations in such conditions. Even in something like a CKD patient admitted in your ward having joint pain, generalized joint pain, you should always have that information or knowledge that you should screen for gout, whether it be using an ultrasound or a possible synovial aspiration. That is one thing. Then the second where you will encounter rheumatological patients in your first year will be with respect to already diagnosed rheumatological patients who have come to your OPD or ward. There you have to understand how to alter or modify the treatment. For example, a patient who recently diagnosed with SLE has come with on already 20 mg prednisolone or ongoing cyclophosphamide infusions. You should understand what next to do because the patient will come in the emergency and then you have to kind of chart the treatment, right? So there you should have an approach based knowledge. Coming to second year, here is where you should know your first part of the Harrison with respect to your approach to clinical syndromes, like approach to arthritis, approach to muscle weakness, trying to again classify these conditions into a possible rheumatological disorder, whether it is a myopathy, whether it is an inflammatory myositis, or it is a neuromuscular disease, a neuromuscular junction disease, or a neuropathy. That approach-based thing is what you should be knowing. Similarly, whether it be an approach to a facial rash, an approach to purpura, approach to an ulcer, is it vasculitic, not vasculitic, an approach to a uveitis with joint pain, what conditions would you suspect? That is very important, especially in your second year when you start taking certain decisions with respect to patients. And also you have to learn how to prescribe rheumatological drugs. Suppose you have a patient with a newly diagnosed SLE, you should learn what steroid dose you should start on, what possible immunosuppressant you can give. This is something that can, this is where possible rheumat department in your hospital can be of great use. Even a 20-30 day posting in your rheumatological department can kind of give you a lot of information with respect to prescribing drugs. So this is also where our course of our residency comes into picture. Suppose you are reading your Harrison's, you are very thorough with SLE, you will know that there is diffuse alveolar hemorrhage that can occur. If you've read your systemic sclerosis, you know that there is pulmonary artery hypertension that can occur. But unless you have this bent of mind that a patient with pulmonary artery hypertension has come to you, now you have to look for a possible systemic sclerosis, even if skin thickening is not screaming out to you. You should have that kind of approach, that back approach, retrospective approach. That is what you should develop. That is why you are doing the residency. Otherwise you could have just read the book and you could have cracked the entrance, but you should go through this to understand the retrospective approach. So that is what, when we see references as when through our DM residency, we learn that when to kind of take an investigation, when to approach a disease retrospectively. Third year, this is where you take a decision whether you have to do rheumatology, not do rheumatology, or any other branch. Depending on that, you will choose your sources as well. If you are doing rheumatology, then definitely you should be thorough with the entirety of your Harrison's along with possible Kelly's, at least tables part. If you are not, then still you have to at least be good with your basic disease, like proper disease-based information that is there in your Harrison, your treatment algorithms, maybe not the trials, etc., but at least the basic treatment algorithms, how to work up a patient. If a patient is highly suspected of inflammatory myositis, what is the complete workup that you will do, and also the other factual information that are important. So that is how we can divide, and yeah, so that is what.
Okay. Thank you so much, Dr. Vishnu. I think very relevant points, and I think you have given a lot of insights into rheumatology as a branch as well. So for the viewers again, what we are trying to discuss now is about each subspecialty of medicine. The corresponding super specialist is actually telling you on how to deal with each of this. I think these are all valuable insights which you can incorporate into your training during residency. Okay. So I think next we'll have Dr. Shinto sir. Dr. Shinto sir, am I audible? No.
Hello.
Shinto sir, am I audible?
Yeah. Very much. Tell me, Rahul. Hi, Rahul.
Yeah. So for the viewers, Dr. Shinto sir is the Hematology faculty at DocTutorials, and currently is the head of the department of the Hematology at the BMH Hospital in Calicut. And sir will be enlightening you about hematology as a branch, and more than that, the training during your residency, how hematology is going to play a vital role as well. So Shinto sir, over to you.
Yeah. Hello, students. Hi, my dear colleagues. So hematology. Hematology was a baby specialty when I joined, right? So after my MD, or I would say during my MD itself, hematology, my seniors, very few people took hematology. The basic reason being there were no much seats. Like all India, there were like I think 14 around seats, all in institutes. So many people didn't go to hematology. One thing. Second thing, the perception was that hemat is a tough subject, right? It has like hemato-oncology, transplant. So it is much of a hard work is needed. That kind of a perception was there. So I went to Vellore for my pre-DM training. From there, I got the idea. Whatever I have seen in MD was not that, because I did my MD from a government medical college. So the exposure was, especially when approaching a hemato-oncology like leukemias, or they don't had any transplant. So exposure was very little. So the entire world was different when I went to a proper hematology program in Vellore. As we all know, Vellore is the where the hemat started, transplant started really under Dr. Maman Chandri. So hemat was my favorite pick, because what I feel is that hemat, if all the broad categories of the specialty, of all the broad categories, Hemat you will see in every specialties, right? So every investigation start with a CBC. So if you can interpret a CBC, okay, including that histogram, MCV, REW, the very basic, that is the basic test you do for anyone, right? So the Hemat starts from the right. So and moving up, if you have a thrombosis, say in a stroke or a cardiac event, thrombosis, there might be need of a thrombotic procoagulant workup, right? Or if you have a CKD, it might be a myeloma, right? Or if you are doing a leukemia or you are doing a transplant, you can't go ahead without knowing a thorough knowledge in infectious diseases, right? So it is everywhere, right? So Hemat, to learn Hemat during residency is very easy. Just look through your CBCs and try to correlate. So a good physician can be a good hematologist, right? So it is basically connecting the dots. So if you have a thorough clinical acumen, you can easily take hematology as a as your pick as super specialty. Okay. So basically, this hemat broadly you can classify into benign and malignant, and this benign and malignant each have their own fund, right? So you can practice benign hematology, you can practice malignant hematology, and both can converge later to a transplant. See, both benign and malignant conditions can be taken up for transplant. So you can be a transplant physician from there on. And for comparing to my personal perspective, when compared to the other specialties, so hemat or even oncology as such is a newer branch and lot of new research and new research breakthroughs are coming. So say, for example, in hematology, for B-cell malignancies, the CAR cell therapies. So this CAR cell therapy is curable for some B lymphomas, and now it is coming in myeloma, solid organ diseases, everything, right? So earlier we thought that CAR cell is something which is very exotic. No, but now that we have also started our indigenous CARs, right? So it is a ever expanding, ever very a burst of opportunities. So there is a lot of things happening in the arena. So it is a new, fresh specialty. So it can be taken up as a very if you have a thorough clinical skill, so very easy to learn. But for me at least, I would suggest this Hemat because it is very easy to learn. It is an overlap between every other specialties, and there is a very new arena, especially if you are going in a couple of years, the cards and everything will be very so common, and you can place your practice anywhere by the from benign to the extremes like full-on transplants, CAR cell therapies, new monoclonal antibodies, and there are because now the seats are also more, right? So that's my take on hematology. So about our program, what we have covered about hemat is that A to Z coverage of all the, basically we have adopted the Harrison skeleton on which we have mounted on our experiences, cases from our practices, and other standard books like Hoffman and latest guidelines like NCCN guidelines. So it can, in a nutshell, it can give you a it's not like spoon feeding, but it's like you have to read on top of that basic skeleton, because you have to read on how I treat articles and new journals. Okay, so that's how you expand on your residency training. So that's from me, Rahul.
Yeah. Thank you so much, sir, Shinto sir, for the valuable insights. And now I think one query from the chat box is regarding the soft copy for the the residency program. So currently in the residency program, we'll be giving you soft copy notes for the essay discussions. I think a very unique initiative by DocTutorials is to conduct a series of essay discussions. I think, this is something which I also wished when I was a resident, because the moment, you're standing outside the exam hall, just about to enter, you're not concerned of anything else in the world than the diagnosis for the essay. You don't want to get the essay wrong for the exam. So I think we have actually, doing a good job with the essay discussions, with a lot of residents taking those lectures as well. So for the essay discussion classes of DocTutorials, you will be having soft copy notes in the app as well, okay, for the essay discussion sessions. I think, since we have discussed hematology, I think a very closely allied branch will be oncology, because a lot of hematological malignancies also come under the purview. So I think we've got Hemant sir, who is our faculty for oncology. So Hemant sir has done his DM in medical oncology, and during your residency training, again, one branch that is less emphasized upon is the oncology segment. So during medicine residency, what is going to be the expected exposure to the branch of medical oncology, and what is expected once somebody finishes their MD or DNB medicine residency? Hemant sir, your insights on that.
Very good evening, students. Absolutely, Rahul Raju sir. I think I still remember my MD days. What we would do in case we had a patient who had suspected acute leukemia. So somebody comes in fever, some thrombocytopenia report outside, we immediately send a peripheral smear. We get the report within half an hour, and we are the fastest to call the local ambulance services 108 and refer them to an oncology center. That's all we would do. So that is how scary probably the field of medical oncology, and that's how probably everyone looks at that. Once a diagnosis of malignancy is made as an MD physician, you really don't want to deal with it. Okay. The same way when probably you've finished your medical oncology and kind of, I am a faculty now of medical oncology, it becomes an extremely secure field that you end up seeing somebody, a physician ends up treating migraine as well, or also a neurologist. Somebody with an AKI, unless really need for dialysis, the physician still manages. Rheumatology is something that probably ortho and physicians end up fighting over, and then probably comes to rheumatologists. But the moment a diagnosis of cancer is made, nobody wants to touch. Nobody really wants to touch these patients, and we really don't know. And that is exactly what happens during MD medicine days, because you are really not exposed to medical oncology, and you really have no idea that when you come out that these are something that is really basic that you may have to end up dealing with. I strongly believe medicine and medical oncology has got a lot of overlap, one of the closest fields to medicine, because I end up seeing pleural effusions every day. I end up seeing malignant ascites every day. I end up seeing somebody in sepsis every day. I see somebody who develops AKI due to the drugs. So it is something that is extremely close to medicine. So one needs to be really good in medicine to go into medical oncology. But at the same time, the same fact remains true that a patient with cancer comes to you, don't tell them that I really don't know what to do, because your medicine aspects still remain the same. So most of the places where probably you will get your MD program or your DNB program don't have medical oncology, but doesn't mean that you will not come often across any cases probably with diagnosis of cancer. So what is extremely important is probably to keep the diagnosis of cancer on top. I still remember when I was intern, my faculty was teaching us somebody with a lung mass, probably initial diagnosis, keep tuberculosis first, second probably some nodule, some fungal pneumonia, everything, and finally cancer was the last. I asked her, why probably you're thinking cancer last? Because somebody has got a lung mass. Like, the diagnosis is called family diagnosis. Make a diagnosis which probably sounds good for your family. Frankly, I believe in case you want to do a diagnosis of malignancy, do it first, don't do it late. So it is extremely important to pick up the diagnosis of malignancy. So somebody comes with a lymph node, neck lymph node enlargement, you have probably suspicion of Hodgkin lymphoma. It is essential to get an excision lymph node biopsy. Don't rely on the diagnosis of FNAC. Many a times the diagnosis of tuberculosis do come, so don't rely on that. So these are very simple points that one needs to remember and needs to learn to how to make up diagnosis of cancer. So that is what probably I have focused on in the residency program as well. The next is medical oncology is associated with a lot of emergencies like febrile neutropenia, tumor lysis syndrome, hypercalcemia, hyponatremia. Very close to medicine. You will end up seeing these patients quite often, and probably that is what you need to learn. The last and most important thing is palliative care. Oncology, you will end up seeing many patients with advanced malignancies coming with either recurrent effusions, recurrent ascites, probably who needs to tapping, coming with sepsis, pain, all other aspects. So once you're done with MD medicine and probably you're going to practice somewhere, you will end up having a patient with cancer coming to you and asking that I am in pain, do something for it. So palliative care and giving somebody a very dignified and respectable death is also a part of a doctor. And that is something that you need to learn. So these are very basic aspects that probably you need to learn during an MD medicine program. I would still stick to Harrison, but trust me, Harrison is not really good enough because like as Dr. Shinto said, the advances are so rapid that probably by the time the Harrison edition comes, there are 100 more things that have come up. But for the basic, Harrison is enough. I would also suggest, in case you have a specialty, super specialty posting to your second year, or at least an oncology department that is there, go discuss with them how do you approach to kind of come to a diagnosis, what workup is needed, and how actually the things are better in the field of oncology. People really think that I am very close to Yamraj. That is not true. You need to know that oncology, probably cancer, is the second most curable disease after infectious diseases. You can't cure CKD, you can't cure congestive cardiac failure, but definitely cancer is one of the highest curable disease. So that is from me. Try to have an open mind, try to see patients with cancer. It is emotionally heartening. Probably it will give a very real good perspective of life as well. Thank you, sir.
Thank you so much, Hemant sir, for your insights about a specialty, which is, again, as I said, not much emphasized during the MBBS training days as well. And as you go through your medicine residency, your thoughts on that will get more refined. And it's very important branch as well. Right. I think one query from the comment section, Dr. Mithun is asking, are NEET SS and residency programs completely different? So, as it goes, see, the residency program is to evolve you into better clinicians. So every lecture is, is actually curated based on that. And it's mostly going to be a patient-centric one. So if I am teaching you a topic on the management of Parkinson's disease, see, during the NEET SS and INISS, those lectures, I'll be trying to emphasize on the entrance-related points alone. But here in the residency program, I also want to teach you, say, for example, if a patient is taking levodopa, carbidopa combination, I want to tell you what time of the day which this drug usually given, number one, and what is the usual, the gap between the doses. And can I take, say, milk along with this, or should I actually change it? Or can I have a protein-rich diet along with this? Is it okay to take multivitamins also? So there are multiple points, which are important from a patient-centric point of view. So these are some queries which, you might not have stressed upon. For example, if I'm asking you about levodopa. Levodopa is a drug that has to be taken on an empty stomach. And it is imperative that you're not supposed to have, say, milk-related products, especially that towards the morning. Suppose you're spacing the drug at morning 7 o'clock, then 11 o'clock, and then at 3 o'clock. Whatever, say, protein-rich your food you're taking or milk you're taking, it's better to take towards the night time rather than the morning time, because this can interfere with the absorption of levodopa. So is the case with multivitamins, which can interfere with the absorption. So these are points, I think, which will be touched upon in the residency program, but maybe not in the NEET SS and INISS program. So I hope I have made that clear. So up next, we have got Dr. Mohammed Niaz sir, who has done DM in infectious diseases from AIMS Delhi. Again, a very important branch is infectious diseases. And so the question that I have for you is regarding the safety precautions that a medicine resident, or shall I put it, any resident, not just medicine resident, because during their residency, you are exposed to, say, conditions like tuberculosis, HIV, hepatitis. So as a healthcare worker, you have to take care of the other person's health, but you're also supposed to take care of your own health. So what are the safety precautions that a resident should actually take care, Dr. Mohammed Niaz sir?
Thank you, Rahul. So, as everybody has already told, residency is going to be very hectic. It's going to be busy, and you always sometimes forget protecting your own self, actually, taking care of yourself, your own health. So it's very important that you keep care of your own health. Like we see a lot of residents actually developing tuberculosis during the residency. It's particularly because they do not pay attention to the nutrition as well as their health. It's very quite sad actually. But we do understand the residency is hectic, but at the same time, make sure that you get your meal in proper time and you have enough protein in the diet as well as enough of micronutrients in the form of fruits and vegetables as well. And now to be specific to prevent infectious diseases, we all know there are a lot of vaccines that are available, and vaccines should be taken by healthcare workers. Hepatitis B, I hope all of you would have taken. If you have not, take 3 doses and make sure that you know your anti-HBs titer. This is very important when you get a prick. You're not going to run and do your anti-HBs titer then. Make sure that you know your anti-HBs titer now before you join the residency so that you need not run for a vaccine or immunoglobulin if you know your titer and you are protected. Every year, all of you are supposed to take an influenza vaccine, depending upon the peak influenza season in whichever part of the country you're working on. That's very, very important. If you're getting sick, you will lose many of your working days. So influenza vaccine can definitely help you in that aspect. And then you have varicella. If you have not had varicella in the past, do take 2 doses of chickenpox. Again, Tdap. Some of these institutes, especially, can get diphtheria cases even now. Now, if you have not taken a Tdap vaccine in the last 10 years, do get a Tdap vaccine as well. Now, other foodborne infections we often come across in residents. We have good vaccines for typhoid available as of now. Do take it if you have not taken already. If you have not had hepatitis A infection priorly, do make sure that you take hepatitis A vaccine as well. So these vaccines are important. You advise it to the patients, but make sure that you are also protected. That's quite important from protecting your own health. In tuberculosis, as I told you, you can get many residents get tuberculosis when they're doing their residency. This is very quite a sad aspect. Now you need to be protected. Nutrition is very important. Your protein intake has to be quite good during the residency. Do not forget your meals. Do not forget your protein. And apart from that, if you're seeing tuberculosis patient, especially in chest clinics, and don't make sure that your room is ventilated, that is your right. You will have to ask your hospital authorities. You want a good ventilated room where you are seeing suspected tuberculosis patient. That is very, very important. And if you have a suspicion of a tuberculosis patient, make sure that it's not just a surgical mask. You need to have an N95 mask so that you're protected. So N95 mask is mandatory when you're seeing airborne infections like tuberculosis, chickenpox, measles, etc. So that's very important. And then hand hygiene, infection control practices, unfortunately, are quite not that good in medical colleges. Make sure that you do a proper hand hygiene before and after coming interaction with a patient. And it's the hospital responsibility that when hand hygiene like sanitizers are available readily in the ward. In fact, should be available in each bed. At least in the ward, it should be available and you should be using it so that you are protected and like you will not be transmitting infection to from one patient to other. So make good care of your nutrition, make sure that you're properly vaccinated, make sure that you're following the airborne infection practices when you're dealing with tuberculosis patient in short. That's it, Rahul, from the protection part. Yeah.
Okay, and sir, a few points regarding infectious diseases, the common diseases that you encounter during residency and approach to it.
Yes, as Hemant said, like ours is a specialty that deals with the maximum number of treatable or curable diseases. So that's quite important. This is a maximum number of cases that a medicine resident is going to face. And the most important one are the tropical infections. You have like dengue, you have leptospirosis, scrub typhus, malaria. And one thing that you should definitely know is the local epidemiology. Now, this is not a section where the Harrison can help you a lot because this is something that you have to know about the local epidemiology. What are the common infections that are tropical infections that are present in your area? That is something that your seniors can tell you. You can also look at local publications and not just the Western guidelines for this. You should also have a good understanding about the antimicrobial susceptibility pattern of various organisms causing various clinical syndromes. If you're going to use ciprofloxacin still for a urinary tract infection, the chance of you getting a cure is very unlikely in the Indian setting. So you have to know what are the organisms causing different infections and what are the antibiotic susceptibility of these organisms. In fact, every hospital is supposed to have an antibiogram which will tell you these details. Unfortunately, many of the institutions may not have, but it is good that, like, based upon your, like, from your seniors, you know that what are the common organisms causes infections and what is their antibiotic susceptibility pattern. And next is that, again, when you're looking at various infections, we have national guidelines for tuberculosis, HIV, etc. There's not enough to learn from Harrison alone. You should know the National Tuberculosis Elimination Program guidelines for tuberculosis. Also, you should know the NACO guidelines for HIV management as well. Now, coming to antibiotics, we know, like, we are all dealing with a threat of antimicrobial resistance. It's very important that we use antibiotics very judiciously. So we first should know that the first question will be whether it's an infection or not. Sometimes patient can present with symptoms which is similar to infections, may not be infections as such, like can be rheumatological, cardiological, other conditions as well. So use antibiotic only if you're sure it is an infection and if you're sure that it is a bacterial infection, and do not use antibiotics for viral infection when it is confirmed. So that is something that has to be very clear. The use of antibiotics, you know that it is now becoming quite specialized and you need a particular training for that. And that is what we have done in the residency app. We have discussed antibiotics in details, and each session is actually discussed with clinical scenarios in mind that you come across in common clinical practice. We separate 18 videos that we have discussed for the management of like 4 antibiotics alone, dealing with each antibiotics. As well as we have separate modules for the management of tuberculosis as well as HIV as well as tropical infection. Do make sure that you check out these videos before and as well as during your residency days. Yes.
Thank you so much, Dr. Niaz, sir. And just sharing the, I'm just sharing the slide. Yeah. Is it visible, the QR code? Yes. Yes, sir.
It is. Can you make it a bit more, zoom out actually?
Okay.
Yeah, it's visible. Yeah, it's.
So this is the QR code of the Pan India Medicine Residence Group of DocTutorials. So you can scan this QR code and join the Pan India Medicine Residence Group. So all of us will be there in that group to guide you during your journey of medicine residency. We'll also be sharing interesting cases in the Pan India Medicine Residence Group as well. Already, you know, the group has got a lot of members and lot of active members. So I'm sure you do not want to miss out on this opportunity to interact with all of us. And in case, you know, you're joining this session late, if you have got any other queries, you can send me a message in Instagram as well. So this is the QR code of my Instagram academic page. So you can inbox me personally in Instagram if you have got any queries with regards to residency, if you are probably watching this session later. Okay, right. And okay. So up next, I think we'll go to Dr. Prashant Gandhi, sir. So Dr. Prashant Gandhi, sir, is the Medical Gastroenterology faculty at DocTutorials for the medicine residency program, as well as the NEET SS program, also the INI SS program as well. So, sir, can you just guide the students about the training that a medicine resident is expected to receive during residency pertaining to your subject?
Hi, everyone. Thank you for the great opportunity, sir. We all know that general medicine is a very vast topic, and we will get to see many things during our residency. A lot of other faculties have briefly touched upon that each year, year 1, year 2, year 3, there will be different things going on. Usually, the first part of your residency will be adjusting to the atmosphere, the new atmosphere around you. And based on the institution where you are working, you would be doing right from basic things, maybe collecting blood samples, putting a central line, maybe sometimes even, you have a lot of procedures from basics to complicated, which you might get to learn over time in your 3 years. However, the first year is probably going to be the most stressful one from mentally, physically to check out your strength. So it's more important that you are mentally strong and your intellect also takes care of your physical body in the form of good nutrition to avoid any unnecessary infections, this and that. Then comes how do you parallelly see your cases and try to get better from an academic perspective also. So from a medical gastroenterology and hepatology perspective, you would be definitely having a significant chunk of patients who you will be getting in emergency with decompensated chronic liver diseases. You will be getting young patients acutely coming with acute liver failure. And again, a medical management can make a major role in this. You will get pancreatitis, acute or chronic, presenting to you when sick to your emergency. You will be having patients coming with upper GI bleed because of various causes or melena because of various causes. So as a general medicine resident, you are going to get emergencies. So from an emergency perspective, we have curated few important topics that are important from a general medicine perspective. How you identify the syndromic diagnosis, manage the emergency part, and then think about what the etiology and when to refer to an gastroenterologist or hepatologist to do their definitive treatment. And later you can again manage the patient in the ICU or the step down unit. So that's very important. Second, you will be made to sit in OPD and see patients. And of course, based on hierarchy, you might be going, seeing the patients, informing to your consultants the important points and trying to make up what the management could be. So we will also cover important approaches to basic symptoms like diarrhea, constipation, dysphagia, odynophagia, and abdominal pain, constipation. So we will be basically seeing these common symptoms like even jaundice. So we will categorize and tell you important points on how to approach these patients in a more scientific way. So you would probably not miss out on the most common diagnoses. That's important. Third, from a student perspective, it's very important that you see the patient from a physician's perspective and then start treating them like a super specialist also. So each time, especially in the second year, when you are going to get to different departments and see them, you should not fixate your mind that I have decided to become a gastroenterologist in first year, so I'm not going to concentrate on anything else. Because each time you should take new avatars to different branches and try to see where you can learn maximum. Because as a gastroenterologist or hepatologist, you are going to get cases of ascites at a very younger age, adolescents, or in a young women, it could be Budd-Chiari syndrome, secondary to APLA. You could be getting thrombophilic prothrombotic conditions presenting as Budd-Chiari syndrome. So you should have a good knowledge. You can't just see, identify the symptom, but you should think why it is happening. And these are the things which are quite important. And yeah, so one is your emergency management, important conditions to be concentrating, I have just mentioned. Second comes the symptomatology of common complaints, which will help you manage cases in your OPD. Third important thing will be also, we'll be covering important topics, how to examine them, what are the important histories you are going to tell, how are you going to tell your differential diagnosis to the examiner. So from passing your exam also, there are some tricks and hacks that probably all the consultants will be, all the faculties will be, putting out as points so that it makes your life much easier from an outgoing to pass your exams also. Sometimes, okay, we also might include a lot of important guidelines, which probably your Harrison's may not cater to, because it gets updated quite, the frequency is not that common. So you have within that 5 years of the next update coming, you would have so many new updates which are happening. From gastroenterology, there's so many things. We would do endoscopies, colonoscopies, ERCPs, endoscopic ultrasound. Now manometry is becoming a very important GI physiology related. We have something EGG, just like your ECG, you have electrogastrography. Now, from a surgical perspective, we are doing procedures like POEM, third space endoscopies, ESD, EMR, you name it. We have a very minimally invasive luminal procedures going on. We would be giving you a brief idea, because 3 years is not enough to even become a gastroenterologist full-fledged, but you would get a crisp idea of what exactly is happening. So from a residency perspective, it is your emergency management, OPD, symptomatology approach, then comes your exam, how to write your answers and how to formulate your answers and answer in your viva. So these are the important things that we'll be concentrating from a PG residency program perspective.
All right.
So,
All right. So thank you so much, sir, for your inputs. And I think we'll now go to Dr. Mithun, sir. Dr. Mithun, sir, good evening. Dr. Mithun, sir? Yes.
Good evening, Rahul. Good evening,
Good.
everyone.
So Dr. Mithun Mohan is the emergency medicine faculty at DocTutorials. So he has done his MD in emergency medicine. And about the branch of emergency medicine, I have done a separate session with Dr. Mithun, sir. I think it's available in YouTube. You can just search it as well. So this one will be pertaining to the common emergencies that you are likely to see as a medicine.
Am I audible?
Yes, sir.
Okay. I was thinking whether I got cut off or is it Rahul who got cut off?
I think Dr. Rahul Raji was cut off, but you can go ahead, Dr. Midhu.
All right. All right. Okay.
Please go ahead with your session. Yeah.
Yeah. Okay. So, good evening, students and dear faculty. Now, I'm supposed to deal with one of the most stressful part of your residency program, medicine residency program. It can be the most stressful part for a lot of residents, which includes the posting in the emergency department as well as in the ICUs. Now, it can also be the most exciting part for a lot of residents as well. Now, there is going to be a wide disparity across the nation in the level of exposure as well as training that general medicine residents are going to get in the emergency department. Because some of you might be choosing colleges or currently doing your residency in colleges, which still has the casualty setup, where general medicine department is posted in the emergency department or the casualty every day, and they have to receive the patients as well as manage as independent units. Now, the other end is that some of you will be doing your residency in some of the medical colleges, especially in private hospitals, where there is Department of Emergency Medicine managing the entire emergency department. Then emergency department posting will come as a separate posting for general medicine residents. You may not have everyday posting in the emergency department. and emergency medicine residents might be initially managing the patients, and only as a consultation basis, general medicine residents might have to see those cases. All right. Sometimes you might be seeing those cases only in the wards or in the ICUs only, right? So the exposure might be much less in those kind of places. All right. If you're working in a casualty setup where general medicine is always there, you'll be getting much more exposure to emergency cases. But the training there may not be adequate. For example, when I did my residency and all, the general medicine residents didn't get adequate training in management of emergency cases. They mainly presented cases which were in the ward which had long workup and all. But the emergency part, like airway management, how the IV fluid management was done, how the diagnostics were done in the emergency department, those things were lacking. Now, it will be much better for those residents working in emergency department having proper emergency medicine residency program. In that, the training will be much more appropriate, but the exposure is going to be much less. So that kind of disparity is going to be there unless and until all the emergency departments are being run by the Department of Emergency Medicine, which is going to take at least 5 to 10 years of time. All right. So this kind of disparity might be there in your residency program. Now, most of the emergencies will be dealt with appropriate faculty belonging to that specialty. For example, neurological emergencies might be dealt with Rahul. Then nephrology might be dealt with Dr. Vivek. Endocrinology by Dr. Karthik. But so I will be focusing more on the general approach of any patient coming to the emergency department. All right. So approach to any patient coming to emergency department, then approach to a toxicological emergencies, then the airway management, how to ventilate these patients in the emergency department as well as ICUs. Those things, it requires a lot of procedural skills as well, which is hard to train in an online platform. So what we have included is simulation-based learning. This is something different. All right, rather than having lectures on these kind of topics, we are simulating all these procedures on how to perform all these procedures on mannequins and sometimes on even real volunteers. Okay, they have helped us to demonstrate how to apply oxygen delivery devices, those kind of things. All right. So I'll be dealing a much more in depth regarding airway management, respiratory management, like ventilatory support of these patients, management of shock, undifferentiated shock. You don't know what's the cause of the shock. Those kind of patients, how will you manage? All right. Then we'll be doing a lot of case-based discussion. I'll be showing some real patient videos, which I have obtained with the consent of the patient or the patient party, like ventilatory management of COPD patients, near-fatal asthma patients, those kind of things. And finally, one additional thing, which I believe all doctors should have adequate exposure or should be exposed in the upcoming future, is point-of-care ultrasonography. Now, ultrasound has invaded into all specialties and is a very helpful tool. And in US and all, general medicine physicians, even now they are carrying pocket-sized ultrasound probes, which they can connect to the phone or to the tab. And you can do bedside ultrasonography on any patient in the ward or in the ICU, in the emergency department. So ultrasonography is the future. And it's very important that you get some kind of exposure to that during your residency, during the upcoming years. So that is something which we have incorporated into the medicine residency program. All right. Now, so those are the basic things which I'll be dealing with in the DocTutorials medicine residency program. That's it. Over to you.
Thank you so much, Dr. Mithun. So next, I think we'll discuss about the neurology segment. So in the DocTutorials residency program, myself and Dr. Pooja will be discussing the neurology part. And we'll have two segments, one for the theory part and then for the practical part. And neurology as a specialty, it's very much patient oriented. It doesn't mean that other branches are not, but again, I think a lot of history taking examination goes into neurology probably than any other branch. So as far as neurology during your residency is concerned, during the first year of residency, I feel it's about interacting with more number of patients, getting used to the common cases, examining the patient properly. For that, I think, it's important, the examination in the proper structured manner, which we have covered in the residency course of DocTutorials as well. Dr. Pooja and myself will be handling that part. So we'll be teaching you on how to examine, say, for example, cranial nerves, how to do a structured motor system examination. So everything will be taught in the residency program. And during the residency, you will see lots and lots of cases. The more cases you are exposed to, the better. And you will have cases which require evaluation and also neurological emergencies as well. And it's important to get trained properly. It's something which, even if you're planning to practice as a physician, I think you have got to be very strong in your neurology. And Dr. Pooja, I think we'll just have a discussion on the approach to neurology from a medicine resident point of view. So Dr. Pooja has done her DM Neurology from AIIMS Delhi, and I have done my DM in Neurology as well from GMC Trivandrum. So we'll be sharing our insights on how to approach neurology as a resident. So Pooja, beginning with you, can you just let the students know what your approach would be?
Thank you, sir. So, neurology, I feel, sir, is very important because, even if you are not specializing in the field of neurology, there'll be certain cases that will be coming to you irrespective of your specialty. Like headache would be coming to you, be you are doing cardiology or gastroenterology. So stuff like that. So coming on to how you should approach in the medicine residency. So the first and the foremost is that you don't have to be scared of neurology, because that is something that I find it was there with me as well, that, neurology becomes initially very scary because half the time we feel that the history is going to be too long. We would know how to approach it. And, the examination is very lengthy and we don't know the correct techniques, and the end of it, how to make a diagnosis. So the first and foremost is that don't be scared of neurology. It becomes very easy if you have a structured approach, if you know how to go about it. And that is what I have tried to do in my clinical case discussions and various approaches to the common neurological problems. And apart from that, neurology is going to constitute a very important in your day-to-day emergencies, especially when you are a first year. After few months, you will be left alone, especially in the night, to handle the emergency by your own self. So you should be trained to handle those emergencies very adequately, because those are very time sensitive, especially when you have conditions like stroke and seizure going on into status. So the first and foremost, you should be learning how to handle the emergencies in neurology. And out of those emergencies, some which are very, very important for you to know would be like stroke, like seizures, management of GBS, acute transverse myelitis. So those are few conditions that it is very, very important for you to know. After you have done those, then there are certain topics that are good to know, which would be like your cognitive assessments, your movement disorders. So if you are interested in neurology, you can go ahead and do that as well. But first and foremost, you should focus on is knowing your emergencies management in neurology. That should be the first and the foremost goal. And second is to start forming an approach to every case so that you know how to go about and you're not scared with the subject in general.
Right. I think, again, as neurology as a branch, as Dr. Pooja said, is not something that you should be scared about. And in the neurology residency program as well, the curriculum that has been structured is in such a way that we are going to cover the topic A to Z, whether it be the approach to common neurological symptoms, for example, vertigo, ataxia, then coming to, say, areas of seizures and epilepsy, coming to areas of movement disorders, the element disorders, and not just that, the case discussion videos as well. So we'll be having case discussion videos wherein we'll be dissecting the approach to a particular case, starting with the symptomatology, why each question is asked, what is the relevance, and how do you come to conclusions. Everything will be dealt with in detail in the neurology residency program. And also it is important that all of you watch the lectures of both the theory as well as practical from the resident course, because we have covered different aspects of that particular subject in the theory as well as practical. So I wish all of you actually go through both segments as well. Right. So thank you so much, Dr. Pooja, for those insights as well. Right. Okay. So I think now we'll have a discussion on some other questions which are commonly asked by the students. One important point that I want to, one second. Am I audible? Just seems I've lost connection. Am I audible?
Yes, sir.
Okay. So one thing I want to discuss with all of you is regarding MD versus DNB. This is a common query asked by many students. So especially the students who have got a good rank and now they have got a few confusions on whether they should be taking MD or DNB, and I get a lot of queries from the students. I think I'd like to stress 5 important points about comparison between DNB and MD. Now, when you want to make a choice, point number 1, it's always the branch over the degree. Suppose you're so fascinated by medicine and you're not getting MD medicine at your rank, you're probably getting DNB medicine. You've got an option of MD pediatrics as well. So now you're confused. Should I opt for DNB medicine or shall I take MD pediatrics just because I'm getting MD? Remember, any day, it's the branch over the degree. Okay, so make sure you give that preference, because even if you're taking DNB, you will be able to get good training and evolve into a better physician. Okay, so that's point number 1. Point number 2, again, a common query. Sir, should I take MD in a peripheral college versus DNB in a good institute? Now, this again is a query that you should take into account after considering all the pros and cons of the peripheral college that you're going to take. Because, see, in the peripheral college, you cannot generalize all peripheral colleges. You try to compare between the 2 colleges. That is the peripheral college and the good DNB college that you are likely to get. Suppose if the quality of training is excellent in that DNB college, then there is nothing wrong in taking DNB there. Okay, because you will be getting good training, which will help you evolve into better physicians. Just because you are getting MD from any college, just do not take that. Make sure it is a college with, lot of, in terms of the training, you must be able to train properly. Suppose you have got good IP exposure, good OP exposure, good ICU facility, then good academic training, good number of faculties, good number of residents, then probably yes. But otherwise, you can take DNB in a good institute. Point number 3 is regarding the pass percentage. Well, previously, the pass percentage in DNB was relatively, or not relatively, was dramatically less compared to the MD. But now the pass percentages have improved, but still it is less than MD. But I still believe that, when you are actually pursuing your dream, the pass percentage should not deter you from taking DNB. I think if it is in a good institute, you can definitely take DNB. Then regarding job prospects, in terms of MD versus DNB, I don't think there is going to be any difference if you're planning to practice in the corporate sector, private sector, no difference. The difference only comes if it is from the government sector. Suppose you're planning to take an assistant professor post in a college, then probably it is going to matter. but it matter in what terms. See, if you are doing your DNB, say from a 500 bedded hospital, you are equally eligible as that of a MD candidate. But suppose in a lesser bedded hospital, the criteria of which is available in the website, in that case, you will have to do additional months of senior residency to be eligible in comparison to a MD medicine candidates. Then coming to the final point, that is the super specialization. Remember, the DNB candidate is also eligible for all the super specialty feeders that the MD medicine candidate can opt for. So overall, if I compare MD versus DNB, I think it's about taking an institute which trains you well. That should matter just about the degree. That's what I feel, because mostly people would go for super specialization, and I think that should not deter you from taking DNB. Okay, so any points to add regarding MD versus DNB? Any of the faculties, if you have got to add any points regarding MD versus DNB? Okay.
Yeah, Dr. Rahul Rajiv, other confusion sometimes students have is about FNB. So they should not confuse FNB versus DNB. FNB is very different, and that's not going to be as equivalent as DNB. Other thing is the 5-year course, which I thought we should be also discussing. If you already have a very clear-cut mindset right after your MBBS, and there are neurology 5-year courses that are there. But again, if you don't have that thought clarity, it's always better to be a MD first and then follow it up with super specialty. That 1 year here and there is probably not going to matter in the long run. And those are my 2 points that I wanted to add.
Thank you so much. Thank you so much.
Sir, and one more point I wanted to add was, like, I've been getting a few queries on my Instagram asking, like, I've got a rank of something like 5,000 or 3,000, whatever it is, where it's kind of on the borderline of getting MD medicine or DNB at a good college, but like they're getting a good pediatrics college at the same rank. But at the end of the day, they are mostly inclined towards doing a super specialty in the adult. So they're asking me if, like, they can go through that path. So again, my advice would be to definitely choose DNB medicine over a possible MD pediatrics or a DNB pediatrics if you are 100% sure that you will be going to a adult super specialty branch. But yeah, if you are still like 60-40 or 50-50 about MD medicine and MD pediatrics itself, if there is a possibility that you would end up liking pediatrics and then later maybe do a specialty in pediatrics or continue as a pediatrician, then definitely you can go towards thinking about the institute or the MD or DNB. But as you yourself, sir, told, that firstly, definitely if you're sure about continuing later in the adult field, definitely go for a DNB medicine over instead of going through this particular route of pediatrics to super specialty adult.
Okay. Thank you so much. Thank you so much. And regarding the next question is medicine saturated? This is something, my inbox has been flooded with, sir, I'm planning to take medicine, but many are saying medicine is saturated. Many are saying there is saturation of cardiologists in the country. Many are saying there is saturation of neurologists. So regarding saturation, I feel for any branch, not just medicine, for any branch, saturation is only regional and not for the branch per se. What does that mean? See, if you take medicine and once you come out as a physician, there is a chance that maybe in the locality where you live, you already have got a lot of physicians around, a lot of cardiologists around. There is a possibility. And again, in that particular area, the job prospects may be less. But it is not that, a medicine or a physician is actually going to sit jobless. He will have jobs. He will have job opportunities. But the point here is that regionally only there can be saturation. So if you like a branch genuinely, do not fear taking the branch because of saturation. Saturation is only regional, okay? And it's not for the branch per se universal. So that's one thing I want to tell. Any other queries on, any points to add saturation in medicine? Because I'm yet to see anybody, who has done MD medicine sitting jobless at home. Okay.
Yeah, I think if we were to look, I was told This I'm talking 20 years back. I was going and discussing about cardiology, and I was told, or should I take pediatric orthopedics or pediatric oncology? When I was getting into PG, I was told by a very senior teacher that remember there is always space at the top. So there is always a space for a Virat Kohli to walk in. So don't underestimate your potential. They say there is flooding of cricketers. Every other nook and corner has got a cricket ground. How will they excel? But we know what IPL has done. So more the flooding at the bottom, very likelihood that you'll churn up out well and do well in your career. So flooding is there even in journal MBBS. 1 lakh seats now compared to say 5,000 20 years back. That doesn't make that you should deter and not take the branch that you like. It's very much like if you take a branch which you like, it's more likely that you'll work harder and get better results rather than take a branch which you think is not so flooded and you don't like. It's more likely that you'll get frustrated and not put your foot efforts to get into the top of the whole thing.
Right. And next query is regarding is super specialization mandatory? Now, the panel, we are all super specialists. So the question is super specialization mandatory? So I'll tell you my honest opinion. See, I feel in the years to come, especially, most of the candidates who finish their MD or DNB medicine will have to do super specialization. I am saying this only because of a reason. Because currently the trend is virtually anyone can go and see a super specialist today. If I just want to go out and see a cardiologist or a neurologist today, I can go and visit. That is the health system in the country. This is not something, that I would support. Okay, everyone should go and do super specialization. There is no role for physicians. That's not what I'm trying to tell you. What I'm trying to tell you is the health system in India is in such a way that, it's mostly going to be, symptom oriented. For example, anybody with a headache currently now would have the liberty of choosing a neurologist rather than, say, a family physician or a general physician. So somebody who has got a chest pain would want to see the cardiologist first. And anybody with sort of dyspeptic symptoms would want to meet a gastroenterologist. So the system is in such a way that, it's mostly super specialty oriented. I am strongly against the trend. I believe, there has to be a proper gradation starting from the family physicians is what I feel. But unfortunately, that is not the case. Still, there will be a role for physicians, no doubt about it. But medicine being a vast science and again, with a lot of changes happening, it's always good that you are an expert in one particular subspecialty, and that will actually, increase the level of expertise that you have. At the same time, I do respect that there will be a role for physicians. You will have enough opportunities as well. But again, in the years to come, I think it will be like more and more candidates will take super specialization. Any thoughts on that? Is super specialization mandatory?
Hemant here, sir.
Yeah, sir.
Working in the field of medical oncology, what I've noticed, frankly, yes, like how you told, the trend is becoming that patients are kind of going in demand for super specialization. Because previously, I still remember endocrinology or rheumatology was not a great idea, especially in tier 2, tier 3 cities, you're going down. But now patients are demanding. But frankly, from the other perspective, as a medical oncologist, there are so many times I do end up relying on physician for all the support. And unfortunately, we are not able to get good physicians. Okay. So in case somebody is a good physician, has done medicine well and is really interested, just because the trend is going towards super specialization, I don't think one should go. In case you really enjoy what you do, you really enjoy being the MD medicine, maybe teaching part, work aspect, anything, I think you should stick to it. Despite the trend being otherwise, frankly, from a super specialist perspective, I am relying every day on my physician colleagues for so many reasons. So they have broader mind of thought. They do think much differently at times. There are times when I really get stuck as what am I doing, but I end up relying on them. So it is extremely important going ahead that we have good physician, especially the concept of family physician is important. We don't have that concept, but just because the trend is that, in case you really enjoy medicine, stick to that.
Absolutely, sir. It's about, doing what you like. Because if you're so passionate about medicine, I think you can stick to it. And I personally have many students or maybe colleagues as well who are excelling, after being physicians. Even yesterday, I saw, a news clipping of one of my juniors who has done MD medicine and opted to be MD medicine itself. And he's practicing as a physician who's doing great service, especially in the, certain backward places in Kerala. And I saw his news as well. So I think if you are really passionate about medicine, you can stick. But again, we were also just trying to give you other insights as well. Any other points pertaining to this question? Okay, right. I think currently we have discussed most of the queries regarding the residency. And I think all these insights would have helped our residents and do reach out to us for any more queries of yours. If you're watching this session later, please feel free to ask your questions in the comment section of this video. We'll be happy to answer the queries as well. Dr. Vishnu, any comments you've got?
No, sir. Thank you.
All right. So that's it. Thank you everyone for joining. Dr. Kamal sir, Hemant sir, Dr. Pooja, Dr. Mithun sir, Dr. Nia sir, Dr. Prashant sir, everyone for joining, Dr. Karthik. So all of you have given very valuable insights, and I hope that this session really motivates the students for their residency as well. And I just want to tell that all of us will be there hand-holding you for your residency via our residency training program and DocTutorials as well. Thank you so much, everyone, and thank you to the viewers as well.
Thank you and good night, everyone.
Thank you.
Thank you. Thank you.
Completing the NEET PG syllabus can be challenging. DocTutorials presents NEET PG 2025 Live Power Pack. Whether you are at home, college, hostel, or library, our live classes will be right on your screen. Simplify complex topics into easily understandable concepts and prepare all 19 subjects effortlessly with our expert guidance. Our NEET PG 2025 Live Power Pack offers live classes for complete coverage of all 19 subjects, 19 tests and discussions, full access to NEET PG Power Pack, quick revision program, recorded sessions for reference, hard copy workbook based classes, post-session tests, and grand tests and subject tests. Our eminent faculty. NEET PG 2025 Live Power Pack, bringing classrooms to your doorstep. Enroll now.